Let's talk in greater depth about sensitivity and specificity. To do that, I want to introduce you to a grid that's used quite often in public health. On this slide, you see a grid with 4 chambers, or units. Across the top we have disease, and to the left it says test. Test, I mean screening test. In the boxes you can see true positives, false negatives, true negatives. So each of the different types of positives and negatives are listed in the boxes. Where it says test, this says positive and this says negative, so meaning people who had a positive screening test would be listed across this row. People who had a negative screening test would be listed in this row. That intersects with do they have the disease or not. So the people who actually have the disease will be listed in this column, and the people who don't have the disease will be listed in this column. So this way we can see the intersection of who actually has the disease and whether or not they tested positive, and who doesn't have the disease and whether or not they tested negative. So the red box and the green box are individuals who the screening tool correctly identified them as either having the disease or not having the disease. The 2 white boxes are filled with the people where the screening test failed, and they either had the disease and were screened as not having it, or they didn't have it and they were screened as having it. So let's bring the last 2 slides together through an example. I'm giving you a population of 1,000 people. 100 of them truly have the disease, whatever that disease is, and 900 truly do not. We want to use a test to distinguish those who have the disease from those who don't. The test correctly identified 80 people as having the disease, or true positives. The test correctly identified 800 people as not having the disease. That would be a true negative. So how would we calculate specificity and sensitivity? Let's go back to our grid. So here's the grid that we saw on the first slide, and again you have on the left-hand column whether or not the test was positive or negative, and across the top those who have the disease and those who don't have the disease. So of our population of 1,000, we know 100 people truly have the disease and 900 truly do not have the disease. So we are going to list that number here under total. We know 100 people have the disease and 900 people do not have the disease. That's a total of 1,000 people. So what else do we know from our example? Well, if we look back, we know that the test correctly identified 80 people as having the disease and correctly identified 800 as not having the disease. So let's fill those numbers into our chart. Here's our chart, and we've placed 80 people have the disease and they are identified as having the disease, and our test identified 800 people as not having the disease and they truly did not have the disease. So now our chart's complete and we can use subtraction to fill in the other blanks. So if I know 100 people have the disease and my test correctly identified 80 people as having the disease that truly had the disease, that means that 20 people who had the disease were told they don't have the disease. That's a false negative. So I indicate that by putting 20 in the box that intersects having the disease with a negative test. My test also correctly identified 800 people as not having the disease, and they truly did not have the disease. However, that means that there were 100 people who didn't have the disease who were identified and told that they did. This is a false positive. To calculate sensitivity, I take the number of true positives and divide that by the number of true positives and false negatives and multiply it by 100. So in this case, I take 80 and divide it by 80 plus 20 and multiply by 100, in which case I get 80% or 0.80. That would be the sensitivity. 80% of the people who truly have the disease are identified as having the disease. So let's look at specificity. To calculate specificity, I need to take the number of true negatives, which in this case is 800, and divide it by the true negatives plus the false positives. That would be 800 plus 100, which is 900. So 800 divided by 900 times 100 is 89%, or 0.89. That means that 89% of the people who don't have the disease were identified as not having the disease. You might be wondering why this is important. Well, let's look at some issues related to false positives and false negatives. So with a false positive, we're being told that we have the disease when we don't have the disease. So all people who screen as positive are brought back for additional, more sophisticated testing, and this increases the expense and burden on a healthcare system. If I have a screening tool that creates a lot of false positives, that is a lot of worry for people because they think they have the disease, and it's an increased burden of expense on the healthcare system. Diseased or positive test labels are often hard to shake off. So if I'm told I have cancer when I don't, I go home and I share that with my family, and different people handle things differently. It might also have implications regarding to insurance or employment. If I have a false positive for cancer, and then down the line I go to have a new job, and they see that I had been screened that way, they might be prejudiced against me with regards to hiring because of the cost of health insurance. So false positives do have implications, and they're often negative for individuals and the expense on the healthcare system. So let's look at the impact of the false negatives. With a false negative, this is a person who really has the disease, but they're told that they don't have the disease. The impact of a false negative depends on the nature and the severity of the disease, the effectiveness of available interventions, and the timing of the intervention. So, number one, the nature and severity of the disease. If the false negative is for cancer, especially an aggressive cancer, that can be very detrimental. I'm told that I don't have the disease when I truly have the disease, and that's going to delay treatment. It's also going to depend upon the effectiveness of available interventions. So again, if I'm not told that I have the disease when I have it, if there's no intervention, well, first of all, we shouldn't be doing the screening, but secondly, the false negative is not going to have much impact. And then the timing of the intervention. There are some diseases where early intervention is extremely important. Others, you might be able to have a little more leeway. So that's also going to factor in terms of the impact of a false negative.